side looks like a pathogenic granuloma. It may be a case of squamous cell carcinoma. That grows fast. It was a peanut-sized lesion, but over the last 3 months, it has gained size and it has become as big as this. The patient says that I've been biting on this particular thing and it has come to this situation. Well, it may be, may not be. We did blood tests were all under normal limits. Only the CRP was a little high. The ASR was a little high, and the serology was negative. I did a biopsy. I did a radiology. The radiology, I couldn't find any abnormality, but something happened to me. That this particular case is, when putting the fingers, it is not a pedunculated lesion. It is a sessile lesion, and it is going underneath. So I went for a CT scan. What did the CT scan reveal? A heterogeneous soft tissue lesion, and that is going from 4.3 to 4.8 region, causing destruction of the bone. Anterior part of the ramus of the mandible was destroyed, and the post-contrast radiograph shows there are non-homogeneous areas over there, which is suggestive of necrosis. So this is a malignancy for certain. I did a biopsy. What did it show? It showed proliferative cells arranged in lobules, test of spindle cells having clear eosinophilic cytoplasm, hyperchromatic. Pleomorphic nuclei were there, prominent nucleoli, neutrophils and blood vessels separating the blood cell tumors were there, focal areas of necrosis, hemorrhage, and some brisk mitosis were also there. So I could see that epithelial component is also going, the connective tissue component is also behaving in a different way. I took help of IAC. It showed S100 was positive, P63 was strong and nuclear positivity, Chi67 was 70 to 80% positive, PAN-CK was positive, and Vimentin was also positive. But it was negative for the alpha smooth muscle actin, desmin, and CD34. That rules out the vascular or muscular component. But the epithelial and the connective tissue components are all growing. So keeping in mind the epithelial, histological, radiological features are a diagnosis of sarcomatoid carcinoma or spindle cell carcinoma was given. So these are the pathogenesis of this, where from the cells came. You all know about that, and you can just go through the slides. We did a surgery of that patient, okay? So a wide surgical excision was done, segmental hemimandibulectomy was done, and from level 1 to 4 the nodes were removed. The patient was doing fine. Got a clear margin from all where. After 4 to 5, this is an aggressive tumor definitely. After 4 months, the patient came with a little pain on the other side and a little swelling of the neck node on the other side. I took an FNSC from the level 2 lymph node and found that there is metastatic cells over there. So metastatic cancer cells on the other side. Now this I have seen over and over and over again. These cancer cells, they can, even the squamous cell carcinoma, they can recur after 1 month, it can recur after 6 months, it can recur after any number of times, despite of our proper surgery that has been done. So whenever you see that it is metastasizing, first thing we need to do is go for a whole body CT scan to see, has it gone to any other part of the body? So I did a whole body PET scan and it showed that the lesion is there in the left cervical area, right mandibular trigo, and also it has gone to the left part of the left lateral part of the prostate. So it has a whole body metastasis was seen in this particular cases. We cannot go for surgery in this particular cases. The patient received paclitaxel and carboplatin. And after 8 months, definitely the patient, we lost the patient basically. So one thing is overconfidence bias. Sometimes we rely on our personal experience or an inflated judgment about a clinician's decision-making activities. It happens. For someone who is practicing for last 20 years, 30 years, 40 years, in thousands of cases. I'm not talking about this particular cases, but a confidence and overconfidence that occurs. We need to overcome that bias. Another thing is Occam's razor. That is, we prefer to, if you see a lesion like that, many times a general dental surgeon or maybe a general, oral surgeon, they don't care to go for histopathologist, cut it and throw it off. So that should not be there. We prefer for the simple diagnosis, this is this. No, this can be this, but this may not be this. So we have to go for always, the simple diagnosis plan doesn't work. Well, this is a 24-year-old male patient showed a soft tissue growth in the vestibular area. We could see the red markings over there. Just looking at the lesion, it appeared to me this must be a case of a vascular lesion, maybe a hemangioma. If not, it must be a hemangioendothelioma or hemangiopericytoma, something like that. We do something that is called a Blanche test, just to see whether the vessels are filling with blood or not. That's the first thing that we do. The dermatologists prefer to use the term diascopy. They use that. But that is not enough to go a surgery for that. This patient had, after doing the test, we see that the patient is suffering, the patient had A negative blood. I got 2 bottles of A negative blood for this patient, and whenever we saw a vascular lesion of like this, I took a vascular surgeon with me during the surgery. But before the surgery, what I did is, this is called magnetic resonance arteriography, to see the vessel flow, the filling of the blood, how fast it is filling, how slow it is filling, that we see in this. We could see some engorgements, but definitely could not be seen. Then I go for something which is called digital subtraction angiography. In digital subtraction angiography, we see how the vessels are after giving contrast, and post-contrast we take images to see the nature of the vessels. So it also shows some engorgements like that. Then we went for surgery. See, if it is a very big vascular lesion, so what we usually do is something that is called external carotid ligation. That is, the external carotid is being ligated. We open it over here in the neck. The carotid sheath is opened. Laterally, we push the internal jugular vein, and then we tie it up with a 2-0 March silk, cover it up with sutures, put a tracheostomy tube over there, and the surgery is done. But when we see a smaller lesions and the imaging shows that it is not a very big, huge lesions, we can have our cauteries and diathermies ready. You can start with this surgery. Interestingly, a little bit bleeding was there, here and there, but not much. And we could excise that entire thing and one go. It looks like an encapsulated lesion. This was the lesion size, 4.3 centimeter, 4.5 centimeter, 3.5 centimeter. And I subjected it to histopathology. And what did it show? It showed circumscribed mass composed of sheets of large, well-differentiated skeletal muscle cells with abundant eosinophilic fibrillar cytoplasm with frequent cross striations, and nuclei were small, round, and vesicular. No mitotic figures were seen. So I gave a diagnosis of rhabdomyoma. Trust me, this was the first rhabdomyoma that I saw in the oral cavity. Before that, I have seen 3 cases of rhabdomyosarcoma, but not a case of rhabdomyoma. After that, I saw, this is in 2018 case actually. I did myoglobin, muscle-specific acting, and DSM, all of them were positive. We could also get positivity of MyoD1 too. And to rule out the epithelial factors, AE13, CD64, and S100 has also been done. So this was a case of rhabdomyosarcoma. You have cardiac rhabdomyosarcoma and adult type rhabdomyosarcoma, which can be, this is definitely the adult type rhabdomyosarcoma. It can be extracardiac type, it can be adult, fetal, or genital type. And chances of rhabdomyosarcoma transforming into rhabdomyosarcoma is almost nil. So you get a cancer, take it off, and you are good. This is the pyramid of Giza. If you just look at a picture of this, you'll find it is in a very deserted place. No people is there around. It is in the middle of a desert. This is the picture. But if you take an aerial view, you'll see that the parking lot is just a walking distance away. So the perspective is different. In order to get a proper perspective, you need to have a 360-degree view angle at all the diseases that you see clinically, histologically, and otherwise. So what appears to be like this may appear something like this in actuality. Then we come to another bias, which is called the hindsight bias. Clinicians perceive past things as more predictable than they actually were, and that impacts the diagnostic confidence. That is called Sutton's slip. Sutton's slip is fixation on the most possible answer, neglecting other. A person was asked, then why do you rob a bank? The simple answer, because money is there. It's as simple as that. It might not be that all the time the thing that you think to be the most simple explanation may not be that. This is a case of a 24-year-old male patient. He came with me with a little bit of swelling, practically negligible swelling, with a salty discharge in the oral cavity. Intraoral findings were normal. Radiograph showed a cystic lesion. This sort of cyst, I did an aspiration and saw that it was cystic lesion. A radiolucency over there. Very simple. Such a big cyst, if it had been a dentigerous or a radicular cyst, there will be a lot of swelling in the outside of the mouth. If that is not present, it is a case of OKC. That's the clinical diagnosis actually. A biopsy, yes, it is a case of OKC. What's the big deal? OKC, we see that is once in every week I see a OKC. See, during my post-graduation, I saw 2 cases of OKCs, and when I went further, Dr. Desai sir's lecture yesterday, the syndrome has to be excluded. That is very important. Every particular single OKCs that you see, we need to exclude whether the patient is having any other problem anywhere and whether the patient is part of any syndromous disease or not. I did skull X-ray and it showed bilamellar calcification of the pulse cerebri and bifid rib of the fifth rib was there. And also I did a follow-up. In 2013, the thing was surgically operated. 2014, it recurred. 2015, some calcifications were seen. Again, a surgery was done. At that time, I removed all the impacted tooth over there. 2016, the patient was fine. 2017, the patient was fine. I followed it up in 2024 with CT scans. Everything was normal. So this was a case of Gall syndrome. These are the major and minor criteria. You need to have at least one major, one minor, or you need to have one major and two minor criteria to be present. Here, in this particular cases, the major was histologically proven recurrent OKC was there, bilamellar calcification was there, bifid rib was there, and also some moderate amount of hypertelorism was also present in these particular cases. I went for the family history. It didn't reveal much, but maybe I have not followed that exact way of going for a family tree examination to find out other members of the families were having this or not. So whenever we see an OKC, we should definitely go for finding it out. We have to counsel the patient that don't go out in the sun or something like that so that you don't develop the basal cell nevoid syndrome. This patient was not having that. So there is a PTCH1 gene related affair. So task saturations, where this follow-up is extremely important that we have been told over the last few days. Yes, it's extremely important. But what happens in a busy practice, it is very difficult to go for this task, multiplying task under pressure, often fail to recheck the delayed results of follow-up. And when the result reports are entered into the system, clinicians focusing on other tasks may fail to notice unexpected findings. This is a very interesting video that is available on the YouTube where the people are playing with a basketball and suddenly a gorilla, this is not a gorilla actually, a person dressed in gorilla moves, they didn't notice that. So they're so busy with playing with that ball. So you can miss out on certain things when you are concentrating on something else. So it has to be, the vision has to be different and vision has to be big. This is a 34-year male patient, came with exfoliation of the teeth and one tooth was mobile. I did an X-ray, the OPG showed punched out radiolucence. Your punched out radiolucence like that, whenever we see, it reminds me, it must be a metastatic carcinoma, it may be a primary intraosseous carcinoma, it may be a melanoma, it may be leukemia, something like that. The CT scan also showed that punched out radiolucence. I did series of CT scans. But then I took a tissue from there, it didn't bleed much. The fibrovascular connective tissue with numerous thin-walled vascular spaces and chronic inflammatory cell infiltrate without any cellular atypia. Now that is very interesting. There is no abnormal cells, but only some vascular radius were there. So I did all these arrays of CD45, 20, CD3, 99 to rule out whether it is a Ewing sarcoma or not. And the epithelial markers were also done, CD17, A1, A3, these were done, to rule out it is not an epithelial malignancy. These tests were done, the lymphatic vascular tests were done, D2-430 was done, it was positive. So it was vascularly positive and lymphatic vascular channels were positive. Keeping this in mind, a diagnosis of Gorham's or Gorham-Stewart disease was given. So this was a vanishing disorder. In vanishing bone disorders, we have to exclude the other things. We don't find out the things, we exclude the other things. There is no cellular atypia, there is absence of the local progressive osseous resorption, no visceral involvement is there, osteolytic radiographic pattern, negative for hereditary and metabolic or neoplastic. And it is being treated with alpha-2b interferon. It is a very difficult surgical procedure, and when it expands, if it is a very expansive lesion, we have to give prosthesis to make it up. This is the etiopathogenesis. Somebody said in 1996, Devlin said it is interleukin. Then he said that there is a hormonal anti-osteoclastic activity. And ultimately, in 2028, Radhakrishnan et al. Supported the feature that these are investigations of lymphanogenetic pathways that is occurring. These are the differential diagnosis. So that is another bias. Clinicians assume that a lesion will present. This was the first thing that I was talking. We assume the thing will, if you see osteolytic lesions, punched out osteolution, we think that this must be a case of malignancy. But all the time, it might not be that. This is the last case. A 6-year-old patient that came to me, a 6-year-old girl patient. She said, I'm having discomfort in the right side. What I did a radiograph, it showed nothing. I took a biopsy. The biopsy showed normal mucosa. Well, I was sure he was not having anything. I asked the patient to come after 3 months. The patient didn't turn up after 3 months. I should have followed it up. But the patient came after 3 years with this sort of swelling, a huge swelling, and I did a radiograph. It showed this ground glass appearances appeared like fibrous dysplasia. But whenever you see in a child patient fibrous dysplasia, it is very important to rule out whether it is part of any syndrome or not, whether she is having any McCune-Alpine syndrome or not. For that, I went for the skin pigmentation was nil, no capillary spots. The growth hormone were normal, the phosphate were normal, endocrinal screening was done, and audiometry and ophthalmologic screening was done, and everything was normal. So we came out that this is a monoosteotic fibrous dysplasia of the mandible. So we gave a standard submandibular incision, opened the flap, and took out the tissues, showed under microscope features of fibrous dysplasia. There were no osteoblastic reaming there. We know what that is all about. So prematurely, just on seeing the patient, we couldn't find anything and we stopped the diagnosis over there. So that is premature closing bias we shouldn't do. I'm not talking about this particular case, I'm talking about all cases. We need to follow up stringently, even if you don't find anything abnormal. So making early assumptions and fail to consider reasonable closures leads to diagnostic procedures prematurely. This is diagnostic momentum. See, last week I saw 4 cases of salivary gland neoplasms. I know after going back, next Monday or Tuesday, if any of the slides I see a little bit of salivary gland, I'll try to think that this must be a case of salivary gland neoplasm only. This is called diagnostic momentum. If you have seen a number of cases and you see the next cases, it's in your mind, it must be that. If you see 4 cases of squamous cell carcinoma, in the next case, this must be a case of squamous cell carcinoma only. This is diagnostic momentum. We need to get out of that. So each case I won't tell about this, but each case is a lesson in humility, in curiosity, a reminder that medicine is both art and analysis. Thank you so much.
That was a very vivid presentation, Dr. Ditto. The spectrum of cases you have shown is very nice. Of course, as you rightly said, the clinical and pathological correlation should be done, and radiographs have to be compared. Then only we'll get. And most of the time, we forget the history. Asking the right question and getting the right answer from the patient. Patient himself will be or herself will be telling the diagnosis many times. So, very nice presentation. Any questions from the audience?
No. Ditto, thank you for reminding Dr. Borges. She said, we write books, not the... Dr. Borges always used to say, we write books and not the pathology. So that's one thing. Second thing about your gingival adenocarcinoma and the breast carcinoma. I don't know how many of you know that oral histology is more important than oral pathology. Third, जब ये MDS करता है तो सबको शेफर ही अच्छा लगता है, एलन ही अच्छा लगता है. Nobody likes histology over there. The most important thing was gingiva does not have salivary gland tissue. So if you see salivary gland tissue in gingiva, baat khatam. It has gone from somewhere else. About sarcoidoid carcinoma, spindle cell lesions, think common things are more common than rare things are really rare. And then finally, we arrive at a diagnosis and we don't make diagnosis. Okay, so please don't make diagnosis. Please arrive at a diagnosis. So thank you. It was a very nice presentation. Thank you.
Thank you so much, sir, for such an insightful presentation. Now, may I now request our chairpersons to present a token of appreciation to our esteemed keynote speaker, Dr. Ditto Dey, sir. Thank you, sir. May I now request Dr. Jayanto Chattopadhyay, sir, to present a token of appreciation to our chairpersons, Dr. Nandini ma'am and Dr. Punya ma'am. Can we have a huge round of applause, please? Now it's time to begin the guest lecture pathologies. Are we prepared for the gathering storm as maxillofacial pathologist? To chair this significant session, may I invite on stage our respected chairperson, Dr. Srinivas Vaniki sir, President of IOM. Sir is the Principal, Professor and Head of Department of Oral and Maxillofacial Pathology at P.F. Nagagodu Memorial Dental College and Hospital, Bagalkot, Karnataka. With over 30 years of teaching experience, Dr. Vanity sir has mentored numerous students and contributed significantly to academics and research. Sir has also served in various academic leadership roles under Rajiv Gandhi University of Health Sciences. A respected academic leader and speaker, Dr. CDEs and endowment lectures at national and international forums. Please join me in warmly welcoming sir. A huge round of applause for sir, please. It's my pleasure and privilege to introduce our accompanying chairperson, Dr. Virendra Kumar B. sir, Conference Secretary, 32nd IOM. I humbly invite sir to grace the stage with his presence. Sir is Professor and Head of the Department of Oral and Maxillofacial Pathology at D.A. Pandu Memorial, R.V. Dental College and Hospital, Bangalore. Sir has over 27 years of experience in academics, research and clinical practice. Sir also serves as a DCI inspector and PhD guide under Rajiv Gandhi University of Health Sciences. His exemplary contributions have been recognized with several academic excellence awards and the Best President Award from IDA Karnataka. We are honored to welcome Dr. Virendra Kumar B. sir, an inspiring leader and visionary academician. We warmly welcome you, sir. A big round of applause for sir. Now, I request our esteemed chairpersons to kindly continue with the proceedings of the scientific session and introduce our distinguished keynote speaker, Dr. T.V. Narayan, sir.
Good morning all. It's my privilege to introduce Dr. T.V. Narayan. He is an eminent clinician, academician and thought leader in oral and maxillofacial pathology and implant dentistry. He served as professor and head of the Department of Maxillofacial Pathology at the Oxford Dental College, Bangalore, and has been in private multidisciplinary practice since 1997. A fellow and diplomat of International Congress of Oral Implantologists. He is also the co-founder of and former co-director of the ITA Study Club, Bangalore, with numerous publications and contributions to the book Partial Extraction Therapy and Implant Dentistry. He is globally recognized for his practice, expertise in evidence-based implantology, renowned for his engaging lectures that blend science and clinical insight. We warmly welcome Dr. T.V. Narayan. Over to you, Dr. T.V.
Introduction. I would actually first of all like to thank Jamie for making that phone call and saying please come. I jumped at it and it's such a pleasure meeting old friends seeing colleagues and some seniors who have not seen for so many years. So it's really a great feeling to be out here. The brand of pathology I've been practicing for the last 30 years is about clinical relevance. And I think both speakers before me have shown the value of clinically translating what you're doing in your pathology practice. And I don't think there's anything non-clinical about oral pathology. It is the most clinical of all the branches that you can have. And I also would like to, put this out to the young ones out here that that oral pathology is not restricted to epithelial dysplasia, oral squamous carcinoma, oral submucous. There's every aspect of dentistry is permeated by pathology. A good knowledge of pathology makes you a great, it can make you a great clinician as well. So do not get carried away into thinking that if you do not have a path in pre-cancer and cancer, you're wasted as a pathologist. That is not true at all. And I will be remiss if I do not acknowledge the impact that these three people have had on my thought processes. They're people who just gave, right, with no expectations. And at some point, I hope I can get close to that sort of a person, right? There are a few learning objectives here. I'm talking about what is clinically relevant today because implant dentistry is here. What you see around implants, things that are going to come around to you as pathologists, you're going to have to assist in diagnosis, assist in understanding the disease processes, and assist in also trying to get answers as to how to fix them. So I'm going to try to first of all talk about the nature of peri-implant tissue, the very fundamentals of what keeps implants in place. Then I'm going to talk to you about what predisposes to peri-implant diseases, the most common inflammatory diseases that we come across. We'll talk about that as well, the etiopathogenesis. We'll talk about titanium as a material and what impact it has on not merely in its surroundings, but as well as reaching out into systemic areas. We'll talk about some drugs and how they impact osseointegration and your implant therapy as it is, and how you may be called upon to assist over there in terms of diagnosis and so on. And there is something that is certainly on the front right now because of the number of cases that are being reported globally of oral squamous carcinoma in the vicinity of titanium dental implants. If time permits, I will also speak to you a little bit about healing patterns of bone graft materials, because that is somewhere that you may be called upon to actually, in terms of research and otherwise, you may have to contribute to help understand how these materials work. And I'll just briefly speak about that if we do have some time. To start with, we need to understand what this environment is all about. Around teeth, and the problem that we've had all along is that we've tried to do everything with implants like we did around teeth. So our understanding from the early days of implantology is that the tissues around implants behave exactly the same way as they behave around teeth. So if you go back into the early 60s, when Orpans and Daggio first described the concept of the biologic width, which is basically the amount of soft tissue that you need to have to protect bone underneath, right? Unfortunately, what they did, today, because our understanding kind of got skewed with some of the biases that Dr. Deeptade was just talking about, is that we saw some numbers and we thought that this is what it's all about, without trying to understand what it was doing over there, right? What they did is they went into a mock, they measured the amount of soft tissue that was there from the bone to the depth of the sulcus, and then they just did an arithmetic mean, which is the worst measure of central tendency for biologic tissues. And they came up with these numbers saying that, so we assumed that this is exactly what's going on around implants. We failed to understand then that the arrangement of these fibers around teeth and around implants are completely different. Because on teeth, you have an attachment. You have Sharpie's fibers that insert into cementum, whereas there is no such insertion around an implant, right? So whatever has to establish over the crest of the implant, and there cannot be an arrangement of perpendicular fibers inserting into that implant. So all you have is a circumferential cuff, which is a very fragile, it's very, very fragile in that sense. So to assume that the same numbers that worked to protect bone around a tooth will work to protect osseointegration around an implant doesn't make sense. It does not hold water anymore, right? And we consistently find that the dimensions of vertical soft tissue that is required to keep an implant intact is far more than what you need around a tooth. We also find that the thickness of tissue that you want to have around at the neck of the implant, in that area where the abutment comes on, is also far more than you have around a tooth. So this started to develop into, the concept itself started to develop to a point where we started to understand that those numbers are now divided into something that is purely genetic, to something to an aspect which is also there's an anatomic component to this as well. So as you go further back in the jaws, you see your papillae start to flatten around natural teeth. The same way you have flattened out emergences around there, whereas the amount of attachment that you have between the fibrous connective tissue attachment or that cuff and the junctional epithelium, that remains determined genetically, that you cannot alter whatever you do, right? So when these guys finally thought that we need to start to make some changes in the way we understand these numbers, they came up with the concept of calling this the supracrestal complex instead of using the term biologic width at all. The problem with the supracrestal complex is that it just takes into account soft tissue, right? So just the zone of attachment of soft tissue, and the sulcus over there was considered the supracrestal concept. Till in 2019, Hamlewon's group actually came up with a more comprehensive terminology where we understood better the peri-implant phenotype and how that helps to kind of preserve osseointegration. So the peri-implant phenotype now consists of a lot more than just that. It takes into account the width of keratinized tissue, takes into account mucosal thickness, which is a lateral measurement here. It takes into account supracrestal tissue height and peri-implant bone thickness. All right. So all of this put together is now so if you had less than 2 millimeters of mucosal thickness, it was thin, greater than, so 2 mm was the cutoff for that. Soft tissue height, less than 3 millimeters is short. Less than 3 millimeters is not good enough to protect integration. So you need to understand that you have to have your implant in such a place or add tissue enough to be able to get greater than 3 millimeters of. So this is, in a nutshell, is what you need to protect osseointegration. Good healthy bone of 2 to 4 millimeters, at least 3 millimeters of attached vertical soft tissue, and at least 2 to 3 millimeters of attached gingiva. So what is peri-implant health? By definition, it means that there are no signs of inflammation. It is really not possible to. Now, if you got what I said about the biologic width and supracrestal complex and so on, it is now not, because our numbers are different from teeth. So it's not really possible for you to define what is a normal probing depth of a sulcus around an implant, because a sulcus in the posterior jaw will be a lot shallower. A sulcus around a one piece or a tissue level implant, where part of the implant is part of the restoration, will be a lot shallower than when it is a bone level or subcrestally placed implant. Okay? So if you start to understand this, you cannot use that 1.5 millimeter yardstick as defining peri-implant health. Okay? Histologically, there's not much different except for the fact that there are no fibers that are inserting into the implant at all. So the health determinants. So what I've tried to do here is create this universe in the form of in the sort of a Venn diagram where I put all of these determinants together, and hopefully we'll come to a conclusion at the end. So it starts with the peri-implant phenotype, soft tissue height, mucosal thickness, peri-implant bone thickness, and the zone of attached keratinized gingiva. Now, all of this is keratinized, but all of this is not attached, because there is a zone which is free, which is where your sulcus lies, right? So this zone needs to be at least 2 millimeters wide for you to be able to have an environment which is friendly for restorative procedures. So I'll go back to the same consensus of on peri-implant and periodontal disease from 2017, where they defined these terms, saying that you have peri-implant mucositis, peri-implantitis, and then you have hard and soft tissue deficiencies around implants. This was aimed not only at just using a semantic exercise over here, but also at giving you a kind of direction as to therapeutic values over here. The one thing that changes this whole environment is when you add a restoration. Okay, when you add a restoration to an implant, you have now taken something that is purely biological and turned it into a cyborg, right? A cybernetic organism. There is a mechanical component that is added to this. You remember the Robocop? I don't think any of you were born during the Robocop days, but you have Terminator and so on, where it's part organism and part mechanical. And now when you suddenly add something which has a moving part possible, all these diseases are biofilm mediated. So if you do not have a way to control that biofilm, there is no way that you can control what happens next. So the idea of trying to so this is with a tissue level implant, you have a very shallow sulcus. And that's exactly what you see clinically on these tissue level implants. The problem is that you will have very, very flat emergences between them. You may not ever see a papilla between those, which really won't be a problem posteriorly as long as you have access to cleaning. When it comes to anterior teeth, your minimum sulcus depth becomes 4 millimeters on the facial, right? Only then will you get those restorations to emerge looking like teeth, all right? And on the proximals, between 5 and 6 millimeters of sulcus depth. So now, if your design of the prosthesis does not seal the environment off, you do not get the hemidesmosomal attachment to the right place to prevent that ingress of the biofilm, you will have peri-implant disease. So that's what you want to see on the facial and on the proximal aspects of those implants. And like I said, once you turn this into a cyborg, the biofilm has to be stopped here and it should not progress down into the sulcus. And for that, we need to start to develop restorations which have these kind of contours which allow a zone of fibrous connective tissue to form the connective tissue zone over there, along with the just down there where you have junctional epithelium and a sulcus. And there it turns from being something concave. Being concave is to allow for mucosal thickness, and turning convex is to prevent the biofilm from going down, because out here is where the seal lies. Okay, so if you understand this and you put all of it together into clinical practice, you can turn patients who come to you like that into patients who look like that when they go back with a couple of implants right in front, and not even trained eyes will be able to tell that there are implant restorations there. And this is how they perform over a period of time, 3 months on, 3 years on, that's what she looks like. So what is peri-implant mucositis? There is bleeding on probing. There are other signs of inflammation. There will be redness. There may be an increase in probing depth, but it's on account of coronal migration of tissues because of edema rather than a loss of attachment. Okay? It is plaque induced at this point. There is only plaque that is responsible for this. Clearing out plaque without touching the implant surface is all that it will take, or refabricating a prosthesis to control plaque better is all that it will take for you to control peri-implant. And this is clearly what you see, because you can see the bleeding on probing, that redness out there, all other signs of inflammation, but there is no loss of bone or loss of attachment. Once you understand that, the next progression from peri-implant mucositis is what we know as peri-implantitis. Again, like I said, the yardsticks we were using for peri-implantitis were the same as we were using for periodontitis, not understanding that they are completely different diseases, right? So it is plaque induced, there is progressive bone loss, it is preceded by a mucositis. There is bleeding on probing, there may be suppuration, there is an increased probing depth, but by virtue of loss of attachment now, but there are no specific bacteria or pro-inflammatory cytokines involved over here. And this is what you start to see. You see some suppuration, you see that there is bone loss, loss of attachment. On a radiograph, you can see that. And this is typically how we start to see peri-implantitis and eventually lose those implants. Again, you can see that there is poor hygiene and poorly designed prosthesis. So the restorative design to control plaque, and if you do not have the sort of restorative design that can control plaque, you will end up with inflammatory disease out here, loss of attachment, eventually loss of that implant. And then you end up with these sort of crazy defects which need some serious fancy grafting to be able to get back to, to a more pleasing outcome over there. So we've come through hygiene and plaque control as aspects or as determinants of things. Some of the risk indicators are a previous history of severe periodontitis. Poor plaque control, of course, smoking and diabetes, the data is out. It's still inconclusive, so it's not as though I don't do implants for smokers or diabetics, I do, but with the understanding of the risk involved, right? Cement in the sulcus is again something that is in occlusal overload, titanium particles. There's a whole lot of things that are out there these days. But just to put into perspective that if you have patients who come to you regularly for their follow-ups, now this was a patient diagnosed in 1996, that's probably before many of you were born, when we started with doing supportive periodontal therapy for what was early onset periodontitis, all the way into 2016, when 20 years on, we've not lost a single tooth apart from the ones that we lost 10 years later when I put in 3 implants for her in 2007 and 8. We lost 1 tooth in 2016, and this is purely because good supportive periodontal therapy was performed. So implants are intact and teeth are intact all the way for 20 years. And then we ended up losing that bridge out there, which was, of course, a poorly designed thing. I ended up losing this implant. This is in 2021. That's 25 years later. Okay. And this is what we have now in 24. She will probably lose this at some point in a few years' time. But by and large, because supportive periodontal therapy is being performed on a regular basis, we have managed to hold on to teeth for now 30 years. Okay, so try to understand that implants are not are not an answer just that you do it and you forget it. It's not a, fire and forget. There's a lot more to it than just that. So we have come through periodontitis as being a risk factor there. Let's look at what are the current concepts in understanding the etiopathogenesis and propagation of periimplantitis. First of all, we need to get that it's not periodontitis. So you do not diagnose it the same way, because probing depth is not the diagnosis for periimplantitis, and you do not treat it the same way, right? The numbers of organisms, so the alpha diversity, which means in the same sample, the diversity on day one of microorganisms around an implant, it changes with the use of antibiotics and the presence of fluoride and other things in our, the acidity of the environment and so on. It changes enough for there to be a much less diverse population of bacteria around implants as compared with teeth. So we cannot apply the same principles of treating periodontal disease to periimplantitis as it is, because the biofilms are different, distinctly different in their signatures, right? So if you go back into literature, more than 85% of individuals share less than 8% of abundant species, right? So that's a big, it's a big difference between the two diseases. And so just to break it down, like I just told you, you start with a high alpha diversity, where you have bacterial growth on an implant surface, which should self-contain, because it is so diverse that there is a competitive environment and there is no disease progressing. But all sorts of things happen. We put our patients on antibiotics, we give them mouthwashes and so on. And if you do that, you reduce that diversity to have a preponderance of beta-lactam resistant organisms. At the same time, because of mechanical forces that went into your implant placement and other things, you have some titanium dissolution products or some particles of titanium that come through, which again go ahead and reduce that alpha diversity further, start to produce potent lipopolysaccharides, which are not now permeated by your any antimicrobial that comes around, and just starts to establish a disease, because now the diversity has changed to a very low diversity, right? So you have almost 1/10 of the numbers of organisms that you had to start with, numbers of species of organisms that you had to start with. So what are the other things that go into play here? How do you get titanium particles coming into play? So for those of you who do not have much of an understanding of implantology to start with, implants are supposed to integrate because of an initial corrosion that takes place, right? When you take that implant out of its carrier, out of its packaging, you are exposing it to oxygen, forming a layer of titanium dioxide, which is affording its passivity. But by virtue of now turning that implant into something that's hard, you are destroying part of the titanium dioxide, right? You're taking away, it's shearing off some of it. Then it undergoes corrosion again. If you do not have an inhibitor of this corrosion, you will get another layer of passivity, another layer of titanium dioxide. But when you now have, for instance, simple thing like fluoride is it will not allow this, it's an antioxidant there, it will not allow that oxidation to occur, and now that passivity is lost. And then you have tribology, which is basically a wear on account of micro movement. So along with this micro movement and the friction that is taking place between components, you have release of titanium particles, and then further corrosion of that, what we know as tribocorrosion. So when you take all of this together, you're losing that passive layer and losing the capacity to repassivate, and you will now propagate the periimplantitis that is set in. So now, try to do the same thing that you did to a tooth. What do you do to a tooth when there is periimplantitis? You open a flap and you put a curate to it, right? You scrape off diseased tissue. On the other hand, you try doing the same thing over here. What are you going to do? You're going to release more particles of titanium into that environment. So where is that going to go? It's going to go into the tissues. So all of this is going on a daily basis, right? There is a constant friction between the abutment and the implant, releasing particles of titanium, which are actually often visible macroscopically and also visible microscopically in exfoliated cells. There are lots of articles now about titanium particles in exfoliated cells over here, and how they modulate lymphocyte and macrophage polarization to how they propagate periimplantitis. So particle release, so one of the ways of treating implant disease used to be that you take a burr and smoothen out. Suppose you had 5 or 6 threads exposed. You take a diamond, take off those threads, flood the whole environment with titanium particles, then take something to polish it off, because you were assuming that by polishing it you will make it plaque resistant, not understanding that by virtue of doing this you were just starting another a sea of changes over there to propagate the disease. The other thing that happens is that titanium does not remain there alone, right? So nanoparticles of titanium in the bloodstream are now known to cause neurotoxicity, to hepatotoxicity, to deposit in the spleen, the intestines. The numbers of problems are really, this is one of the later articles that you can get on the immunological and tissue reactions to titanium particles. And this is far removed from the implant, right? Can you see what's going on here? That is like a local hypersensitivity reaction to titanium. It's not in the sulcus, it's not in direct contact, but it's at a slight distance. So this is because you can now see that this tooth is certainly under some, under heavy load, and there is a lot of tribal corrosion. If that were not enough, we are not only using one type of titanium, we are using titanium, grade 4 titanium, which is clinically pure titanium, and we are using an alloy. Now the nature of disease around these alloys is completely different, right? And I've been trying to put together enough data to be able to, get it out there, to try to make this validated that aluminum and vanadium are bigger culprits in this whole scenario than anything else. So by itself, the alloy seems to be fine when it is unchallenged. But whenever there is, it is challenged through corrosion or through wear, then the aluminum and vanadium seem to suddenly change. So we see so many of these cases which are in function for 8, 9, 10 years. You don't see actually any signs of periimplantitis. But if you look at the radiograph, all along that implant is unzipped, right? And this is a very typical finding with all grade 5 titanium implants, right? You'll see a whole series of radiographs here which just pops out. If you'll notice, there is no bone, nothing attached to this implant right now. It's just popped out. So this is, again, another one. This is going to pop out. This one doesn't look like there's any bone loss, nothing there, right? Take a look at that. It just pops out. That's how it looks. It just pops out. There's no suppuration, nothing else. Just pops out one day. And again, this was sent to me by a friend in Pune saying this implant is functioning for 10 years and today I just see it looks like this and it's shaking and it's just coming out. I said that's grade 5 titanium, right? And true to true to form, it is grade 5 titanium. Grade 5 titanium again. Grade 5 titanium again. The same pattern of bone unzipping. It's a reaction to the particles rather than a plaque-induced disease over here. All right. Okay, so we've gone through tribocorrosion, titanium and aluminum and vanadium particles out here. Is it only a local phenomenon? And I think we need to start to think about this a lot more, that hypersensitivity and systemic effects are a reality. I was just telling Dr. Ranganathan and Rajiv and Dr. Ujjal yesterday about how Dr. Borges called me once to talk to me about one of her friends who was an anesthetist, saying she underwent a few implants, and just a few weeks later she developed this inexplicable hemolytic anemia. Right? I have another patient, another dentist's father, who developed a completely inexplicable autoimmune hepatitis and died of it. This lady had the implants removed and the anemia reversed. Okay, so the hypersensitivity and from systemic, dissemination of the titanium is something that, and there is ample literature now. Orthopedics is replete with it because the size of the implants is so much more, right? It's difficult for us to imagine that these small screws can cause the same problems, but all it takes is nanoparticles. These are some of the newer articles on thing, and if you'll see, liver, intestinal, spleen, kidney, and neurotoxicity, there's nothing that is spared. All right, they found deposits in the lungs. It's all over the place, and often it is just dental implants. That brings us to our current state of, drugs that are being used for all sorts of reasons. Anti-resorptives. We're using anti-resorptives for osteoporosis. We are using anti-resorptives for metastatic tumors to bone. It is essential for that, right? There's no question about that. You have other drugs like SSRIs. Many a time a patient does not even disclose the history to you because they find it stigmatous to tell you that they're taking an antidepressant of any sort. I have a friend who's taking an SSRI to lose weight. So you don't even know what people are taking these drugs for. Fibromyalgia that encompassing all diagnosis is being treated with SSRIs. And these patients, they showed disastrous failures when you place implants in them. And if that were not enough, there are enough non-anti-resorptives that cause the same kind of drugs. For those of you who are interested in understanding bisphosphonates, you have nitrogenous and non-nitrogenous. The nitrogenous varieties are the more dangerous varieties as far as osteonecrosis of the jaws goes. We've heard always that IV is worse, that oral is not so bad, but I can tell you that oral is just as bad if the circumstances are right. This is a great review for those of you who want to delve a little deeper into this. And so, we were talking about this, that you have an implant placed some time ago, and what happens then? Now, this patient had CA prostate, and he had undergone, chemo and all of that, and was on zoledronate for a long period of time. For the first time he came to me was in April of 21, when he already had this implant, and there was just some dull pain in that area. So that's a grade 0, stage 0 PONJ, right? You can see that the bone changes are happening in the radiograph. Now, this patient did not want anything done at that point. Somebody else had done this implant for him, given him this embracing prosthesis. And I said, okay, come back to me whenever it bothers you enough. He came back to me in September of 23, and now we had proceeded to stage 1. We're still in stage 0, but it was bothering him enough to want to do something about it. So I took that crown off and placed a healing abutment there and said, just leave it alone. As long as that area can be kept clean, you should be all right. Then he came back in January of 24, but now he came back because he had started Zolendronate again, because he now had meds, and then he had a second primary, and now they started Zolendronate again. So this is something which had kind of quietened down, is now showing a stage 2 BONJ with exposed bone. Eventually, that implant had to be taken off. Unfortunately, this poor patient, he died a few months into that second. But that's what you feel like doing when you see patients like that. This thing started in 2019, November of 2019, and I'm still treating her. Okay, one wisdom tooth extraction in 2019. It happened in November. She came first. When she came first and showed me, I said, I got her history. She was taking oral idofros, that is ibandronate, and she was taking a full cocktail of all sorts of drugs. She came to me. I said, it's small. Let's fix it. She was like, very, very wary about doing anything about it, and then COVID and all of that. By the time she came back, it was in September or something, and she came back like this. She brought her this big chunk of bone, which had sequestered, and she came around like that. Very difficult to treat. Very, very difficult to try to even. I mean, what do you do? How do you console them? You can't do surgical work. Nothing. I placed a couple of implants for her in several years before. By now, she's got pain here, she's not keeping things clean, and she comes back a few months later with the right side. These are implants that were integrated and functioning for more than 4 or 5 years. Right? What do? Take those implants out in this situation. So one of the things that I have found works pretty well once you've developed the disease is that photodynamic therapy, I've seen it working really well in some of these patients, but even that, it's touch and go. It's always a toss of the coin, literally. So that's when you want to do that, right? Go walk up to the closest noose. What's interesting in these cases is that you take that bone and you'll find that there's plenty of osteoclasts. The problem is not with the population or the numbers of osteoclasts, it's the function of osteoclasts. So this itself is a clue to you, if you've got a biopsy like this, that what you're dealing with is an osteonecrosis of the jaws, because you have dead bone and you have plenty of osteoclasts. One good way to preempt all of this, any postgrad, one could venture a diagnosis on looking at this radiograph as to what this patient has got. Pardon me? Just take a look at the radiograph, and that should tell you. Okay, so this patient actually came to me asking for an implant. Right? Her orthopedician said, it's okay. By all means, go get an implant done. Fortunately, I know her since she was a child because she's my sister's friend. And I said, osteogenesis imperfecta for the last 40 years that I know you of. And are you on any bisphosphonate? Yeah, I'm taking zoledronic acid. Right? What you're seeing is dentinogenesis imperfecta, by the way, on the radiograph. But what I want you to see is what's going on with the lamina durae. Do you see them that thick ever? See, look at the thickness of that lamina dura, right? So sometimes you just need to look beyond what, like you were saying, you just need to look at what you're seeing. And I find that this intraoral view is the best way to make this diagnosis. No fancy CBCT will give you this, because there's so many, so you just get caught up in looking at it too closely. But take a look at the lamina dura and then take a look at the trabecular pattern in the maxilla. That pattern is completely changed. This is because the turnover has stopped. There is no turnover, right? And the reason you get osteonecrosis only in the jaws is because this is the bone that turns over. You don't have that happening in the femur, right? So you don't get to see it. One of the things that you can do is get a thorough clinical history, of course, but do a serum cross-labs. It's an indirect way of trying to understand whether this patient is prone to osteonecrosis or not. A beta cross-labs is used as a prognostic indicator for therapy of osteoporosis, fracture risk, right? So if you have a low CTX value, less than 150 picograms, that patient is at a high risk for developing osteonecrosis. And if you have to do essential treatment, put them through a pentoxifylline and vitamin E prophylactic protocol. I like to keep them on for 2 months before I do the procedure if possible. But it's often not because they're in pain or something of that nature. So at least 2 weeks of pentoxifylline before you do any procedure. If it had to end with bisphosphonates, easy. But other antiresorptives, the worst thing about denosumab is that there is no clarity. I mean, though it says half-life is 20 days, it actually presents itself with osteonecrosis sometimes months or years later, right? So that's denosumab. Then if it were to stop there, we'd have been happy. But there is so many different classes of drugs which are not anti-resorptive but have an anti-resorptive effect. Okay, so like this patient had an extraction done in February of 23, lives in Pune, so I went to see him in Pune 6 months later because his extraction site was not healing. A very secretive guy, so very secretive. I mean, one of those scary ones, right? You feel like you're in a movie or going into some CIA thing or something, where they whisk me into whatever. At the end of it all, he was taking imatinib for CML for a long period of time, and nobody elicited that history, right? Went ahead and did the extraction. He had lichen planus in his mouth, all of which is related probably to the imatinib. So there are too many other drugs that cause these problems. SSRIs, this is the sort of disasters you see. You think you've done your job really well, place your implants, look nice on that day. I have a few patients now where these sort of disastrous failures, and then what you have nothing to work with. Because implants come out, bone comes out, everything is gone. All right? Then the last cobra over here is the squamous carcinomas that. So this is being reported since 1996. Okay, I found a case series from 2025 last month, October, where one group has reported 22 cases. I have seen 5 of them so far. So I mean that's because people have referred 5 patients to me. I don't know how many more are floating around. Can you put a cause to effect relationship here? No, it's very difficult to do that. It's not. But it stands to reason that when you have a source of chronic irritation, you have these particles of titanium that come out there, they change that microenvironment, they change the inflammatory profile in that area, and it's all related to the same sort of signaling that Dr. Jayanti was talking about early in the morning. So it's very likely that it is contributing because it's always directly in the vicinity, and because it is gingival carcinoma, and because it involves bone early, usually they tend to be a lot more. This is the last of that with 22 cases. And one of them that came to me looks like this, and she was referred by a friend. That's not too much to go by over there, but the histopathology is pretty clear. So if you put all those things together, what we started with is understanding the peri-implant phenotype to the design or restoration to hygiene and blood control and how each one influences the other out here. And then how the history of periodontitis and smoking, diabetes, etc. influences the initiation and progression of disease, tribal corrosion and aluminum vanadium drugs and all of that, and the sort of diseases that you could get around there, including the systemic reactions and oral squamous carcinoma. Do I have any more time? Yeah. All right. The bottom line here is that implants are the brown stuff when compared to teeth, okay? And there's no denying it, right? So my message to whoever I speak to is that work with the teeth. You know, they are far easier to hold on to than implants when they get diseased, all right? And I mean, we have enough and more of those in our practices. So the implant should be, there's nobody who I know who died of titanium deficiency, right? So if you remember that, then implants are for those who need them only. So just to conclude that the peri-implant supracrestal complex is a very special environment. It's totally different from the periodontal complex. The microbiome is different. So you cannot treat it conventionally the same way as you treat teeth. The best way to debride and clean a biofilm of an implant, in my view, is with just plain normal saline followed by a laser decontamination, low-level laser, photobiomodulation. All of these things seem to work much better around implants because it's always non-contact. There is no release of titanium particles from doing something non-contact with them. We know that some drugs can modify. If I have another couple of minutes, I'll go to show those histopathology. Do I? All right. Yeah? No, it's okay. I just wanted to, just highlight how bone graft, three different mechanisms of grafting materials that are used in, because you will come across these sooner or later. Somebody is going to ask you, send you a core and say that, look at this and tell me what's going on. What happens with any sintered particle is that it does not undergo resorption. So it just gets incorporated into new bone that's growing around it. And a lot of it lies free in the cancellous component. So you will see these particles hanging around like that and get incorporated into newly formed bone. Whereas with all other graft materials like corticocancellous allografts to alloplasts and so on, it's always a resorption followed by a replacement. Okay? So there's a big difference between the two. One is not going away at all. One is getting taken away and then getting replaced. The most interesting of the lot is dentin, because it's almost like replanting a tooth. You first get an ankylosis, and then that gets resorbed and replaced by bone. I thank you all very much for this, first of all, this opportunity, and for graciously giving me that little, for my ungraciousness of extending time, and thank you all for hearing me out. For those of you who want to know what this is, it's an image of star trails. It's 100 photographs that I took over a period of an hour, which are stacked together with one common focal point, that's the pole star there. And a lot of the things that we do are like this. You need to peel back the layers to get out of your teachers whatever you can. All right, thank you again.
Thank you so much, Dr. Narayan, my friend, for throwing different information about the treatment-oriented pathologies. Most of us are practitioners here, and most of us are doing implant also. So many of us probably don't think of the pathologies related around implant, whether it is inflammatory or tissue related or material related. Thank you so much. Probably we might have to have another chapter incorporated in the textbook, implant related pathologies. Anyway, doing modification, probably we can add one more topic into that. And we should be appreciating him because he is oral pathologist and also implantologist. So oral pathologist can do whatever we want.
Narayan, thank you for showing us.
Yes, no, that's all. Yeah.
There is a test, okay, but it's not available in India.
Yeah.
And it's ridiculously expensive wherever it's available also. So, but find out.
Again, he has proved that we are all clinical oral pathologists. I have one more question. Earlier, I remember reading Staphylococcus lugdunensis as one of main bacteria causing periapical periimplantitis.
That's what
In the beginning,
they're
now
not-
probably,
Yeah, that's what there's no, so it's like that. Everybody will study one set of organisms and come up with a thing, but it's a very small, very low diversity this thing, about 8 or 9 species, that's it. Unlike periodontitis where
Probably in the beginning they found new variant of Staphylococcus. They named it as Staphylococcus lugdunensis as one of the main bacteria causing periimplantitis. This is almost nearly 1.5, 2 decades ago.
Can I say
Thank
something?
you.
Very nice lecture, Dr. Narayan. Actually, we've just recently done a systematic review on implant-based neoplasia.
okay.
So we have found a lot of Western literature giving us evidence of squamous cell carcinoma and even sarcomas developing in and around the implants. So I feel that in India there is underreporting of
It
these
is
kind of
very
cases, and I think clinicians should be more careful while placing implants in any patient, because I feel that they're not assessing the bone condition and all the soft tissue conditions, and because of which, so probably we might have a overdose of all these pathologies coming up in the next 10 years. And because whatever, when we did the review, there's no literature reported in India at all, and all the literature which is reported is from the Western literature, and there's a very high incidence of squamous cell carcinomas and other sarcomas which are
There are
developing
a
around
few case
implants.
reports from India, like Neil Bhattacharya and then Yazar. They reported a few cases, but they're all individual case reports. But I agree that there's no concerted effort at trying to highlight that there are problems around implants.
Yeah, so I think clinicians who are doing implants should take more care in while placing implants, so that this kind of pathologies might not arise later on. Otherwise, I think
That's why I do this lecture at every implant
Yeah, that's
meet
true.
that I can. So.
Because I don't know how much of pathology the clinicians know, that how they have to take care of the patient.
Yes.
If they start doing practice, then only they'll understand. Many oral pathologists don't do practice.
करेगा तो आएगा.
Sir, is there any known carcinogenic agents identifying the fabrication of implants?
No, I mean, there is no. I mean, if you take titanium as a particle, there is no literature to say that it is carcinogenic. But like I said, it's possibly the modification of inflammatory pathways around that implant, which is possibly bringing about these neoplastic changes.
Sir, what is your take on call? Some of the cases of implants, when we removed from that due to the reasons, we found some granulation tissue beneath it.
Mm-hmm.
Could it be called it as a periapical granuloma due to implants?
It's just granulation tissue. I mean, not so much of a thing. I would not give it. But yeah, there is this thing of retrograde implantitis, epicoectomies for implants. All of this has been done in the past. There have been people who made those possibilities as well. So.
Okay, thank you, Narayan. You're an inspiration to all our young postgraduates like Sandesh Nayak.
Thank you, sir, for that insightful presentation. I am sure the audience has gained valuable takeaways from this session. May I now request the chairpersons to felicitate our esteemed keynote speaker, Dr. T.V. Narayan, sir. Please give sir a thunderous round of applause.
जितने भी मतलब चीज़ें स्टडी हैं वो सब पैथोलॉजी में भी
Moving on, I now invite Dr. Chaitanya Babu sir, Senior Professor of Oral Pathology, to felicitate our Honorable Chairperson, Dr. Srinivas Vanaki sir. A huge round of applause for sir, please. May I also request sir to felicitate our respected chairperson, Dr. Virendra Kumar D sir. A huge round of applause for sir, please. Thank you, sir.
हेलो हाँ जी सर हाँ चल रहा है मैं कुछ नहीं लेक्चर दे रहे हैं अभी एक लेक्चर हमारा दूसरे क्यों नहीं कर सकता अभी ये नहीं आ रही टाइम चल रहा है
So respected new EC members, you kindly stay here. So after this symposium, we have to go for a group photo. So the newly elected EC members, if some of you are not there, please inform the message to them. So after this symposium, we'll go for a group photo.